Actually, live YouTube live started. Sorry, it started live. Okay. I think we can start now. Let me start the recording. Okay. And apart from doctors, few of them joined just now allowed, and I asked them to join back to our YouTube live. And I'm getting that Amit Chakrabari secretary. Okay.
Let them, doctors, if they mention it as doctors, please let them in on the Zoom, because they have questions, opportunity to ask questions.
Sure. Yeah. Okay. Shall I go and start the recording now?
Yes.
Okay. I'm going to start now. 1 minute.
Dr. Saravanan, you can go ahead and start first, please.
Recording in progress.
Yes, recording started.
Vanakkam. I'm Dr. Saravanan Ramalingam. I'm a trauma surgeon in New York State, and I'm governor of American Tamil Medical Association. And I welcome everyone on behalf of American Tamil Medical Association and COVID-19 Tamil Task Team, which is we started last year in March 2020, rapid response, a crisis response team for the pandemic. Without going into much detail, we are doing this webinar since last year. I mean, I don't even have a count, maybe 70 or 80, much more than that. And I wholeheartedly thankful to all the speakers who spend your time here for the presentation, and also your services for the humanity. Also, I welcome everyone, the viewers and all. Let Dr. Mupana, you can go from there, please.
Thank you, Dr. Saravanan. Good morning, everybody, and good evening for viewers from India. My name is Saraswati Mupana. I do pulmonary critical care medicine in Boston, and I would like to thank American Tamil Medical Association COVID-19 Tamil Task Team for giving us this opportunity to share our experiences regarding COVID-19 during this crisis. And thanks to Dr. Saravanan Ramalingam as well. So without any further delay, I would like to introduce our speakers today. This session is going to be more roundtable, and it's going to be on common topics, what everybody has questions. I do adult medicine. As an adult medicine specialist, I have questions, so many questions myself regarding kids. If I get a call regarding a child question, then I tell them, okay, let me help you with my pediatrician contacts. So I feel it's going to be a great session. Please pay attention. And if you have any questions, we have the YouTube live going on as well, and you can post your questions there. Thank you. So, Prem, could you mute everybody, please? Thank you. So our panelists today are both from US and from India, and we really try and thank them for their time and the energy they put in for this meeting. Our first speaker is going to be Dr. Umakant Katwa. He's a pediatric pulmonologist from Boston Children's and also affiliated with Harvard Medical School here in Boston, United States. He is the president of the API chapter for sleep. It's called APIOS. He's been a dear friend, and he actually spoke for, he was one of our panelists last year as well, and we welcome Dr. Katwa.
Thank you.
Thank you, Umakant. Our next speaker is Dr. Neelam Mohan. By the way, Dr. James. Dr. Neelam Mohan is an alumni of Osmania University. She's a director in pediatrics, gastroenterologist, and at Medanta Medicity Hospital in Gurugram in Delhi. And she's very popular in India. She's done a lot of these webinars, and also a lot of questions she's answered on YouTube as well. Our next speaker is Dr. Vaidishwaran. He's a former assistant professor of pediatrics, Kipak Medical College, and he's an alumni of Stanley Medical College as well. He's a consultant pediatrician now for Lakshmi Narayanan Kids Care in Chennai, Tamil Nadu. Welcome, Dr. Vaidishwaran. Our next speaker is Dr. Chetan Trivedi. He's an MD pediatrics, MD and diplomate in pediatrics. He's an honorary assistant professor, infectious disease consultant. He's from Ahmedabad, India. He's an alumni of PG Medical College, Pediatrics in Ahmedabad, and one of his expertises is in vaccines. So we welcome all the panelists. Thank you very much for your time and energy today. It's going to be a roundtable discussion. So as I mentioned earlier, we have lots of questions from the community and physicians as well. And the questions will be directed to one of the panelists. And if any other panelists want to chip in as well, please feel free to do so. We're not going to rush on this session. There are so many questions that we may end up doing another session also on kids. Thank you. Thank you very much to everybody. My first question is to Dr. Neela Mohan.
Yes, please. I can hear you.
You can hear me. Thank you. Thank you so much for that. Thank you for coming on this presentation today. And my question is, during the first wave in India, kids were not that much affected, right? During the second wave now, kids are more affected. And there is a thought process that there could be a third wave in India and or anywhere else also globally, and kids will be affected even more. Could you tell us why that's so, please?
Very good question to start with. So at least in India, what we documented in the first wave, that we had ICMR statistics told us that we had around 2.5% of the kids, or less than 4, I would say, in various statistics that were involved. But when it came to the second wave, overall, we have shown 12% of children being affected. So that answers your first question, that more children be affected. Number two answers for that is that actually the proportion increased significantly a lot. So some protagonists argued that the whole cake, the pie increased because it never went up to 1 lakh cases a day, when we went up to nearly 4 lakh cases a day. So there was more family members, and thus the children who got more involved. That was one of the presumption. But having said that, most experts believe that definitely they saw more number of symptomatic children also, and more severe disease. And we are now sure about it with all the available evidence that it was related to the mutants which we had called 1617. And we had 1617 mutant, which is the 0.21 is called the Delta mutant, 0.1, 0.3, but 0.2 was the worst one. And now, as you are aware, this mutant is in UK, and it just started with few hundreds. But last I read a day back, you have like 40,000 cases in UK, 95% are this Indian mutant. And they have also said, and WHO has said, that this is extremely transmissible. If one person gets it, the whole family gets it. And more virulent, they are seeing severity. So that was there, but you also asked me about the third wave. So now for the third wave, there are the answers to that is 3. One, we are going to get more adults getting vaccinated. So what we saw in the second wave, we saw in the first wave, we said anybody more than 55 or with comorbidities were involved. So the government started vaccinating them, and the doctors, of course, the healthcare workers. But in second wave, the entire people who got infected with 20 to 45 was the biggest cohort in India. And the deaths were also in this, and the death rate went up to 2.5% plus. So the death rate was more because, again, this group got infectious and the virus mutated. So what we are assuming is that in the third wave, God forbid, the virus also wants to live. So the virus is trying to get into a susceptible host where it can multiply, where it can get easily. So we are assuming that the virus will not have all that group who are vaccinated. So children will get relatively unvaccinated group. And in case, we don't know, God knows, in case it mutates, then the children are going to get more affected because they did not get the vaccine and they were more susceptible and the virus got smarter. So that is why in India, first wave we were short of PP kits and masks. Second wave, sadly we got people oxygen lack also. So third wave, the government wants to be smart and the experts wanted to be smart. We said, let's prepare and improve the infrastructure throughout the country so that we are able to give equity of care, urban, district, community, poor, rich, and improve the pediatric healthcare facilities.
Thank you. Thank you. That was very well said, actually. Umakan, Dr. Umakan, question to you. How about the scene in Boston, studying the difference between what was happening last year and this year? We'll go to the third wave in US later.
So I think if you look at Massachusetts, it is one of the highest vaccinated states in the United States, and close to 50% population is almost more than 50% population are close to second dose, and most to 2/3 of the population have at least got one dose of vaccine, and both Pfizer and Moderna. And if I yesterday I went into the town and looked at around, and most of the people are walking in the town. Some people are wearing masks, most are not wearing. Following the CDC recommendation that when you're outdoor and you're vaccinated, you don't need to wear vaccine. You don't need to have the mask. I think overall the cases have dramatically gone down, but it is not zero. But recently I heard that some of the travelers from India who have come here have gotten this 1617 variant, which is called as the Delta variant, which was seen in India. Some cases have been reported. So people are a little bit scared, especially in the Indian community, that what is the protection against this variant. And recently Pfizer put out a data that if somebody had got a Pfizer vaccine, it has 88% protection against the COVID-19 Indian variant vaccine, the mutant. So we don't know how it happens. You may be less symptomatic after you get the vaccine with this variant, but people who are not vaccinated, people who are got one vaccine may be at higher risk. So overall, I think the pandemic is coming down. We don't know we will have a third or fourth wave, but at least the vaccination rates are pretty high in Massachusetts.
So while we are on the vaccination topic, what is the age limit? Now, as you are mentioning about the CDC coming down on the age limit for pediatrics, right? What is the age limit we have started vaccinating here in the US?
So initially the first recommendation was more than 18 and people started getting vaccination. And after that, the recent trials confirm safety and efficacy of the vaccine of 12 and above. So all the children's age 12 and above, unless there is an absolute contraindicated, are getting vaccinated, including my son who is going to be 13 soon. Most of the kids are getting 2 vaccines. The trials are already there to check the immunogenicity, the safety and efficacy of the vaccine in the younger population. So before the school starts here in Boston, Massachusetts, which is in September, we are expecting all the kids above 6 to get vaccinated. But also there are trials from 6 months and above, especially Pfizer, one, to identify what is the effective dose. Number 2, what is the immunogenicity of that dose? And thirdly, obviously, the safety of the vaccine in that young population.
Thank you. Thank you so much. We are on the vaccine topic, so I'm going to ask you questions to Dr. Trivedi. He's a vaccine expert. So I've had attended other groups, and what they mentioned was in India, you have to bring your identity card, mainly like an Aadhaar card, or maybe like a driver's license or something. But the kids, even if they're not 18, they could be 15, they bring something else like little different. They look 15, they look 14, but then the Aadhaar card says that they're 18, or their ID card says they're 18. Is it safe? One of the questions was, is it safe for a kid of maybe 15 years or 14 years to get the vaccine, which is currently given in India? Please.
Thanks for the opportunity, first of all, Dr. Bhupana. In India, we have the lowest age limit for vaccination is 18 years, because we are going to vaccinate, Government of India has approved only more than 18 years. So you can't give the vaccination less than 18 years because it has not been proved the safe, and immunogenicity is, of course, this trial has just been begun by the Covaxin brand, that's a Bharat Biotech vaccine, which is already now into the process of trial of more than 2 to 18 years of age group. And first they have taken a 12 to 18 years age group. So they have just given the first batch. I think there are a few centers, Patna, Nagpur, and all these centers. But before that, I think we cannot give vaccine to those less than 18 years, even if they look more than 18. because we have to follow something like the government law, because it has not been proved safe. So it is not advisable to give it before that.
Saraswati, you are muted.
You're muted.
You got muted. Yeah.
Am I unmuted? Can you hear me?
Yes.
Yes.
Thank you. The question is for Dr. Vaidishwaran.
Yes.
He is from the southern part of India. So I wanted to see if there was any difference in the vaccination in kids regarding age group.
Yes. Okay. So thank you for the opportunity. So as Dr. Trivedi said, here in India, the vaccination is according to the recommendation of Government of India. It's only for children, adults more than 18 years. So less than 18 years, right now, we are not vaccinating any children, and trials are going on, as he mentioned. But Pfizer vaccine, it is available for children more than 12 years. In the US and even in Singapore, many children are getting vaccinated, those who are about 12 years of age. So I don't think even maybe a few weeks back, there was this, some clauses were modified so that Indian government emphasized that there is no need for any trials before, if suppose the vaccine is being approved in other countries, suppose if it is approved by FDA, there is no need to held a trial in India. So suppose if that happens, probably the Pfizer vaccine, if it arrives in India, probably that will be apt for the children more than 12 years. And I don't see any reason Covaxin being a good choice, because it's a proven technology, an inactivated vaccine, which all the kids are taking for even for the other diseases. So I think Covaxin should be a good choice. If it is available, probably it should be a good immunogenic vaccine in children particularly.
I think there's an issue of Pfizer vaccine. Those vaccines have been approved to use more than 12 years in other country. But in the government, they want the studies to be done in India before it has been rolled in India. So that's the issue. If they bypass that, that's a different thing. And whatever available vaccine, 2 vaccines available as of now in India, Covishield and Covaxin. The Covishield, having because of the data of that clotting issues, they are not allowed to even do the trials in pediatric population. So whatever is left is only Covaxin. Only thing is point in favor is because it has been age-old technology. So that's the only thing. So they can even do the trials safely.
Yeah, definitely. Since it's a proven technology and already children are getting vaccines which are made up of the technology, obviously it should be a good one. Except for that clotting issue, I think even your Covishield should be a good vaccine, because it's a live vaccine. It's going to produce. Obviously, theoretically, it's more effective and more immunogenic than a killed vaccine.
So, Dr. Trivedi, where does the Pfizer approval or the procurement in India stand? Because there were some rumors or talks and the news that the government is trying to approve, and finally they are giving into the non-requirement of the local clinical trials, and then they can use in pediatrics. Because even though the mRNA technology, we don't have any knowledge, we were all skeptical about using in pediatrics. We were very scared because what it will affect the young developing organs. And fortunately, so far the short-term reactions have not been there. We don't know what are the long terms, but definitely the short term is doing okay.
I just wanted to make a
Go ahead, please.
Yeah, 2 things. One is Zydus is doing its trial in India, and they started it in above 12 years, and we are expecting them to be proposing it for the emergency use in July. So let's see what they have to say, because their trials are going on from 12 years onwards. So that's number one. I wanted to say that we have something even before the Bharat Biotech Covaxin studies. The Covaxin study started in the first week of June, and they just started with 12 to 18, and they started predominantly of 60 Pune, where doctors' kids who came forward to, I just wanted to put in a word. So they will, and yet we are yet to go be less than 12. So after that, they plan to go less than 12 and that. But as we all know, Pfizer took 9 months to come. They started their trial in July 2020, and they came into the market April times. So I don't think that we should be able to get the Covaxin before the end of this year. And that's why we will have to look for Pfizer for 12 to 18 and that. And the government is talking about it. When they put the circle of the other vaccines, they've talked about it in August. But right now, what I'm being given to understand is Pfizer is not, they're already overbooked with UAE and other countries, their commitment towards them. So they did not, even though the government asked from India's side, they were not able to say yes because they had too much of commitments to give for the other countries as of now.
Yeah, I would like to just add, the Zydus being an Ahmedabad-based company, they have, they are in the DNA-based vaccine. But yes, Dr. Neelam Madam on is right. That they already started the studies in the pediatric population. But the thing is, it is not still available for adults also. So I'm not sure whether they will come up with all the results and they will be getting UA all throughout more than 12 years. That is to be looked at it, because this is a DNA technology. It's a different, totally different technology.
Yes.
So yes, you're right.
So Dr. Trivedi, while you're on this topic, is there a dose difference between the adults and the children?
Ideally, that's the way we do the studies in the vaccine, because first what we do is we do it in a healthy, like animal study. Then we go to healthy adults. Then we go to the high-risk patient. Then we go to pregnant and lactating women. Then we go to the age less than 18 years. Then you decide what is the best dose, depending upon the different lot-to-lot variation and everything they do. So it is yet to be decided. So that's why they are going first 12 to 18. Then they will go to 6 to 12. And the main issue is between 2 to 6 years, because there you have to look at the dosage, which dose will be the ideal dose, which will not cause the side effect, but they will be immune. So that is a tricky situation. So to say that rush for the pediatric vaccination, but to really prove it is safe and effective, it's a really difficult job. So yes, you have to do the different studies of the different dosages. But as of now, I think they'll be doing the same dose, and then they might have that option of different group of different dosages. Because we have seen in AstraZeneca, because first low dose and high dose, so standard dose, that sort of combination gave more long-lasting, rather higher antibody titers. So we never know that should be done, that will be done or not.
Right. So
Probably from our, probably from our
sorry, go ahead, Dr. Vaidishwaran.
Yeah, yes, I'm sorry. So probably from our experience with other vaccines, the dose, I think it should be the same dose or probably more in children, not less.
So because in pediatrics, always it's all dose dependent, right? We're always calculating the doses according to the body weight and everything. So that was the reason I asked this question. Dr. Mohan, you have anything to say?
Yes, so that's what I wanted to say. The studies which have been done by Pfizer and now Moderna, which they are doing, so I've read about all their phase 2-3 trials. So they use the same dose in 12 to 18 years, and it was only in less than 6 years and 2 years they are checking the other doses, which both half the dose and that results are going to be out. But for 12 to 18, they use the same dose as in adults.
Right.
Yeah,
right.
That's correct.
Makan?
Yeah, I agree with you. So most of the children more than 12, they're using the same dose. And when you go below that, particularly as Dr. Trivedi and Dr. Mohan said, that when you're starting, for example, here in the US, we give vaccines for flu for infants, right, from 6 years and above, 6 months and above. So for that point, to bring this to that level so that COVID can be approved for anybody who is more than 6 months and old, you want to make sure that the dose what you're using, because it's unknown technologies like Pfizer, like mRNA, they don't know. So they want to go with a smaller dose to see whether it's equally immunogenic. That means they reduce antibodies. Number 2, the side effect. Number 3 will be, do they need a second dose, and when do they need the second dose? Is it like 4 weeks, 8 weeks, 6 weeks, 12 weeks? So kids have a different level of immune reaction to the vaccines compared to adults. So they want to make sure that it is safe enough. So I think, again, this is speculation. So the younger the children, up to 6 months to 6 years, there may be a slightly lower dose. I think eventually after 6 years, I think it will be a similar dose as adults. But again, we need to wait for the trials.
Is there any clarity on booster doses for Pfizer vaccine?
So people have been talking about
in kids.
In kids, we don't know exactly, because remember, like we as in US doctors were one of the first to get the vaccine, even before the general public got the vaccination. So we are far ahead from the first dose of vaccine than most of the kids who are getting the first dose of vaccine. So they are studying the antibodies in doctors who got the vaccines in the beginning, and then seeing with the second, third wave, are the doctors getting reinfected? These are the studies ongoing from different hospitals in different counties in the US. And eventually there is a rumor, again, I don't know, there are talks about getting a third booster dose during our 9 months or a year from now. So we all will be ready to get the dose. But for pediatrics, again, they are much behind the curve to understand their level of titers, antibody titers, so that they are protective against the vaccines, and hopefully the newest strains will also be covered. So we don't know. But the talk on the street here is, in our circle in the hospital, is that we should be expecting a booster dose sometime in winter of 2022.
So
Can I
Sure, Dr. Mohan.
I wanted to know, you said that even you had some Indians coming with the Delta mutant 1617. So my question to you is, did the Pfizer vaccine, escape these mutants? Because in India, we had this paper from IMS, which is not, the study's out, but the paper is not yet written. And they said that they were able to identify that both the Covishield and Covaxin, nearly 50 or 70% escaped, even though they took the vaccine. And they were even, so my question to you is, what is your, we also know that the South African strain, even there, they had an issue that they escaped the mutant. The mutant escaped the vaccine.
Right.
So what is your thing about this Delta variant? What is the same USA?
I just was reviewing this because we will be definitely, because the UK, the Delta variant is increasing in prevalence of the newly diagnosed cases, and we don't think so we'll be far away. And as soon as the travel increases, between US and India, and especially families start traveling, so that's when you bring the variant here. The question is, are you completely immune from this variant? The answer is probably not. When you give vaccinations, my take on this is, when you give vaccinations to gazillions of people in the street, not everybody has the same immunogenicity for the vaccine, based on their immune system, based on the situation when they got the vaccine. So those people who did not get the right amount of antibodies, or they did not get enough of protective antibody titers, those are the ones who are likely to get vaccines. And again, we have seen patients here, people get the Indian variant in the people who got Pfizer vaccines. Those 1 or 2 cases make the headlines, right? But that doesn't drive the narrative. So meaning it's also good and bad. Bad in the sense that people are susceptible for these things. Good things is they are very, 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 very uncommon. So the Pfizer recently published that they studied the protection against the Delta B1617 variant, and they found 88% of the people are protective, meaning it's not 100%. So people who got the vaccine, in my opinion, when they are going out, they should be still wearing those protective devices, because recently they put out that the COVID spreads most by aerosol, by talking in close environment. People were initially cleaning with disinfectant wipes, all the surfaces, sneezing, droplet, all thing has gone. I think the aerosol is the most important thing. And people right now, what they're doing is they're doing indoor parties. And as you said, that if one person gets, everybody gets. So if you are immigrants coming here, if they're not quarantined for 13, 14 days and they go to a party, a lot of people have social gathering. People are so sick and tired of staying at home. So they want to gather. When you are indoor and you're speaking for about half an hour, 2 hours, and this is so transmissible, so even though you have vaccine, you will get infected. So there is no guarantee of infection. Whether you develop a disease or you die, that is the only protection you're getting from the vaccine.
And that is the huge protection.
Yes, that's a huge protection.
So the message we're telling to the community and everybody is, please get your vaccines.
Vaccine. Yeah.
Thank you. Question to Dr. Trivedi. What should be the gap between 2 doses of these vaccines? Let it be Covishield or let it be Covaxin. What do you think is the gap? Because it looks
a burning question.
Changing recommendations.
Yes, this is a burning question for the Indians, because there are so many issues. Initially, when Covishield was brought, like they started the Covishield vaccination, initially it was 4 weeks gap. And then they gradually increased to 6 weeks, then they increased to 8 weeks, and now it is 84 days gap. it is mandatory between the 2 doses of Covishield vaccine. Now we know that that original study which was done, it has been, there are major cohort which was been studied for a gap of 12 weeks. So that way there is a scientific reason behind it, because whatever the study is there, it is because with the gap of Covishield 2 doses, 12 weeks. So yes, it is good, fair enough. If you increase the gap between these 2 doses of Covishield from 1 month to 2 months to 3 months, up to 3 months is fair enough. But if you go beyond 4 months, the immunogenicity goes down. So if you keep a gap of more than 4 months, then it will be less. So ideally, it is 84 days gap is fair enough. Now, issue is for Covaxin, it is just the 4 weeks, so 28 days. So what they have done is just 28 to 42 days. This is a gap which has been recommended by government. Now, technically speaking, if you are in the sort of second wave, there are so many cases surrounding you in the community. At that moment, exactly what happened? People have received 1 dose of Covishield, and they were to give the second dose, and there were so many who got infected between these 2 doses.
Yes, exactly.
So what we have seen is both dose of Covishield or Covaxin, if you have received, almost it protects 100% from severe COVID and the deaths due to COVID. So when you are in the midst of this wave, so many pandemic, then it is better to get vaccinated even at shorter interval. But now gradually we are coming out of this wave, and then the background incidence of the disease is less. I think we can definitely wait for that 12 weeks and get better immune conversion, seroconversion. Because we know that if you keep a gap of 12 weeks in Covishield, definitely better seroconversion and better antibody level. So that is about the 2 doses of Covishield. But for Covaxin, it is still been the same 4 weeks to 6 weeks. That's the gap to be followed. So that's about the thing. But we have to follow the government guidelines, because there are issues. Because the people who have received Covaxin, they are getting 2 dosages. But unfortunately, if they want to travel to the other countries, it has not been approved, because it is not WHO pre-qualified as of now. But the people who have got Covishield, there are many students who are just going to travel, and they have got only 1 dose. And they are waiting for that turn to come to finish the 84 days, and they are not able to finish the second dose. So that's an issue. But because of the government guideline, we can't help it. We have to just wait for that 84 days. And now I think university also, they are accepting it with the first dose of Covishield, and they are allowing them to travel for the further studies.
Thank you. Thank you.
Very important point, Dr. Trivedi, what you mentioned. But I think when you're in the pandemic, you need to cover as many people as possible, as much as possible, rather than trying to get the best immune response. You may miss that time, because with the 1 dose, it was 30 to 40% coverage.
It was done because we wanted to cover susceptible people. It was only the study when it came from UK the joke was 48 hours earlier, when the government had said yes for the increased gap we expert, 48 hours later, UK reduced the gap from 12 to, and that was because they got scared of the wave that was coming.
Exactly.
So I just wanted the community and everybody to know that because the protection that was there after the first vaccine was close to the tune of 77% to 80% till the second dose, they wanted to cover more people.
Yeah.
The experts gave that idea to the government that instead of giving the gap, which was earlier 4-6 weeks, they wanted it to be increased to 3 months, so that we are able to give more people the first dose. And we were able to get 10 crores a day, a month. That was very less, while we want to do 1 lakh a day. So we need so many, 1 crore a day. So we wanted 30 crores a month, but we were producing 10 crores. So we had no other option but to increase it, so that study, because the study from the UK had shown that the efficacy lasted 3 months.
No, I think it's a very important point.
The government did it to cover more people in the susceptible range.
I think in this,
there is one ongoing study. Yeah.
So I think in the pandemic, I think we are always trying to catch up the virus and other vaccines. It's getting smarter, and we are like in the process of following. And nobody's right or wrong. We try to do with all the best intention. And it's very difficult for the policy people to keep on changing, flip-flopping. It's easy to talk for us back and forth and review a journal and come up with a new idea. But at a policy level, I completely understand it is extremely difficult to build a policy and next day change the policy.
You know, it's
That
like
is
the
what-
flu vaccine. It's like the flu vaccine. Every year, the flu mutation that gets smarter, and we are coming up with a little bit different vaccine than the previous year. We're always chasing a tail. That's what I tell my patients. The vaccine, the virus is little smarter than us, and we're still trying to figure it out. And it's the same with the COVID vaccine as well. So, Dr. Trivedi, you had anything to say before I move on?
There is one ongoing study, which is, almost 515 healthcare workers who have been given a Covishield as well as Covaxin vaccine,
Exactly.
2 doses. They have just studied that antibody level, anti-spike antibody, and just they wanted to see what is seroconversion. In that, in between whatever, this is a preprint analysis, it's an ongoing study. What they found is Covishield after single dose also there was a seroconversion and it was protecting. While Covaxin, rather after completing 2 doses only, that it started protection. So that also in favor of increasing the dose gap between these 2 doses of Covishield. So that's fair enough.
Thank you, Dr. Vaideshwaran. Any
Yeah,
thoughts on the
as far as this Covishield and Covaxin is concerned, Covaxin is an inactivated vaccine. Naturally, it needs booster doses to keep the immune response to optimum level. And Covishield, since it's a live vaccine, obviously it's going to produce a good immune response even with single dose. And as far as this gap of 12 weeks is concerned, and in this second wave, this pandemic, I think even if the gap was 6 weeks as before, many people would not have been eligible because most of them got infected. And if you get infected, anyway, the next dose is after 3 months from recovery, probably. So anyway, this gap might not have mattered much. Even if
ultimately add to the pool of immune people. So that's what we want, either by natural infection or by vaccination. We want to build up the herd immunity.
Yeah, I also feel since most of the healthcare workers, they are even obviously all of us got vaccinated except very few, and most of us are exposed to the patients daily. So probably this subclinical exposure itself will act as a booster for us, and I don't think we need boosters later. I don't know. Maybe some researchers later on this aspect.
Yeah. The booster is mainly for 2 things. One, okay, we are the immunity can come down and we are boosting. And 2, it could be the development of the new mutants also. So we are trying to catch both of them. That is in adults. And I'm thinking the same concept applies for the kids also. So one quick question while we are on the vaccine topic I have. So if a child gets a Covishield vaccine first dose, the second dose of Covishield is not available in their geographical location. And as Dr. Trivedi was mentioning, people are traveling, the kids are also traveling for school these days. Can they get a different type of vaccine? And if so, which one? Please.
I think kids in India, they are not going to get less than 18 years. So whatever the question will be, it will be for adults. You got the first dose of Covishield. And there are many people who want to get the second dose of whatever vaccine available. But it is not been proved or they are not studied. Their results are not out. There is only study which has been done in, I think, with AstraZeneca's Covishield followed by Pfizer, this mRNA vaccine. That's the only study which is available. Their interchangeability, it has boosted the antibodies to a very good level. So that's the only thing is available. But in India, the Pfizer vaccine is not available.
Right.
And so the thing is interchangeability as of now, no, because we don't have any data.
No, but
ideally,
I wanted to ask this question to Maka. You said while you were making a statement, you said we are going to look in the doctors if their antibodies level. We are thinking about the booster dose. This is the lines you use. So my question to you is that do you think the level of protective antibody has a difference? Because what we hear sitting at home in India is that the Pfizer vaccine gives antibodies which run in hundreds to 1,000, while as poor little Indians who are using the Covishield, including me, my antibody titer after 2 weeks of the second dose of Covishield was just 23. And the neutralizing antibody, which we talk about. So what are your comments on the level of antibody? And we understand now that there are 3 types of antibody. One is the neutralizing, the antibody or the spike antibody or the neutralizing antibody, what methodology you're using, and what is the significance in terms of protectiveness, and how are the studies being designed now, where you said that you might get a booster dose for those who are. So can you tell us more about that?
So Umakant, before we go to that question, Dr. Mohan's question, can we finish up with my question regarding interchangeability? Covishield and Covaxin. Dr. Mohan, the question is for you, please.
So as he said, there was only one study, and I don't know whether the results came out. It was UK, because doctors were very excited. Those antibody are not there. We are wanting to find out if there is any other vaccine, and we should be able to take a booster, if at all we want to take a booster dose of some other vaccine. So the Sputnik vaccine, it uses two different vectors. So though the first dose is different from the second dose, so you might call it interchangeable, but it is a different vector they've used. And so we really don't know whether one of it we can use. So they have used different vectors to increase the antibody level, but that is their antibody. They've used different antibodies, different proteins and different vector. But the only study that came was from UK, where as he was mentioning that after Covishield, and I don't know the results, whether the results are out. Check where that results are, because everybody is waiting for that.
No, there is a result that's showing that it's a good immune coverage and immunity, antibody levels are good, very good. It's a good boosting.
Okay, so the reason I asked this question,
the answer will be there that once the papers are out, and we are able to say that, because a lot of public ask us, like, my antibody is 3, my brother's antibody is 2. So they all ask me, can we take another vaccine? Now it is available for money also. You can buy in the private sector. Indian government has given 25% vaccine to the private sector to sell it at 150 rupees margin than the MRP. And that's a different part of the story, that Covaxin gave its rates obnoxiously high as compared to any other vaccine, which is asking for $20 was too much. So that is what they are saying, and this is a question which is asked, and that's why I wanted to know what the Western world is thinking about it.
See,
so
this question, just a minute, just this question will be more applicable for the students who are going to travel in US, because if they are given 1 dose of Covishield here, they go there and if they receive the this Pfizer vaccine, because that is available there. So there it will be very much fruitful exercise.
So this question is not only relevant to the pediatric population, it's also to the adult population who came to India, traveled to India, and then because of the crisis, they got stuck there and they thought something is protective. So they ended up getting the vaccine, which is locally available, the Covishield or the Covaxin. But now on the return here later on, when the lockdown eases up, their question is, should I get both doses of Pfizer? Should I get both doses of Moderna? Or which one should follow? And there are so many questions. I still feel, at least to do with the adults, I still feel we don't know a correct answer for that. It's all like, okay, take the vaccine and just get ourselves protected. That seems to be the message what we are giving. So, Dr. Vaidiswaran, any thoughts on before Umakant answers Dr. Mohan's question, please?
Yes, ma'am. Actually, this interchangeability and giving a different vaccine in different dose, it also has some other significance. For example, we take DPT, we give for children. So as the child grows up, we decrease the dose of diphtheria antigenic content because of the fear of immunological reactions which can take place. For example, serum sickness. So if we give the full dose, the normal dose of diphthetic antigen after 7 years of age, it's going to produce a lot of reactions. So same can happen theoretically with other vaccines. Suppose a child has taken one vaccine and they are giving another vaccine. This immunological reactions, we don't know what will happen. So that's still a possibility, and we should keep that in mind also.
Very, very well said.
Thank you. Thank you. Umakant?
So regarding this question, so regarding the booster dose, there are actually studies going on where they want to give Moderna vaccine for people who got Pfizer vaccine as their primary immunization to see if that is better. And they're also vice versa, like people get Pfizer who got the Moderna vaccine. And as far as the protective antibody titer, so there is not a single level which say, below that, it is when they do these studies, they take about what is the 50% protection against the population when you get the vaccine of the convalescent plasma. If you have an antibody titer levels of 20% of a convalescent plasma, so that means they take a person who get a COVID infection, like you got an infection, and that is the best, immune response. You are actually fighting the virus, and your levels are pretty high. And if I get the vaccine, what is my 50% chance of protection is if you have 20% of that level. So if you, Saraswati, you got COVID and your convalescent plasma is 100, right? I'm telling you this. And now I get vaccine. And what is my protection level? So I say that if my levels are 20% of your levels, then my protection is 50%. So that is how they use analysis in the statistics when they use vaccines and studies and all the things. And actually, it is said that to get the protection from the severe COVID, even 3% convalescent level is enough to get the protection from the severe level. That means even you get one dose of vaccine, your immunogenicity may not be that high. You are protected against the severe infections. But the question is, we are not testing these viral antibodies in all the patients in the community, right? Like I am not getting my an antibody tested. Nobody gets tested. Only people who are in the research are getting tested, and that data is extrapolated to the population. Okay, we studied 1,000 people, and this was their level, and this is how it's going to happen in that. So as far as the antibody levels are concerned, we don't know. So the whole point here is, if you get the alternative vaccine, is those convalescent plasma level increases rapidly compared to somebody who got Pfizer as a third booster versus Moderna as a booster in people who got Pfizer. So that's an open question. We don't know what it is.
Thank you, Umakant. Another question I have is, it's open to the panel. Vaccines, the kid receives a vaccine, and are they safe to go out without a mask? Umakant, scenario in US first, please.
Yeah, so and I can only talk about 12 and above because we're giving vaccines only in 12 and above. So again, as per the CDC guidelines, if you get both the vaccines, okay, and you're outdoor, there is no need for wearing the mask. But as far as if you get one vaccine and you're going out, and I think, in my opinion, because it's an aerosol infection, so you should wear the mask and you should be protected until you complete 2 doses of vaccine. And that's what we are recommending. In fact, my kids are so diligent about the mask, then sometimes we forget. And the kids in the school, it has been so drilled into their head that, most of the kids, they tell, my son said that, and I've only got 1 dose of vaccine, I'm going to wear the mask. So yesterday we had gone out in the community. So we even walking outside on the street, we took out the mask, but my son did not take the mask. I think that is a good education in the school, what they're doing. We should wear a mask until you get full 2 doses of vaccine in kids.
That's commendable. Your son being a pulmonologist kid, he's doing
it's the school, they don't listen to me. It's all the school.
That's true. But I do have to differ on that particular point. I run an adult pulmonary clinic as well, but it's adults. So my patients who come to the clinic nowadays, actually, because of the CDC came out with this rule, you got your 2 vaccines, you're good to go, you don't have to wear your mask. I still insist, there is a CDC clause as well. If they are in a clinic or a healthcare environment, and if required, okay, then it is important that you wear your mask. I tell my patients, you're in my clinic, the other patients could be there, the staff are there, they could be immunocompromised for any reason. Kindly wear your mask till the visit is over. And they listen.
Absolutely. That's a very important point. See, when CDC came, the CDC just put one sentence. A lot of times, they're trying to catch up. And most of the sentences, when you put in a public, and especially mask is it has become a political issue. It's not a scientific issue anymore. So the people are on both sides of the aisle trying to rip each other out. So in this situation, you need to be very careful and very clear and concise. And you cannot give one sentence, you don't need a mask. That is a pretty big sentence. It is not a small sentence. So especially if somebody comes to the hospital, we insist them to wear the mask, whether they're vaccinated, not vaccinated, because they may carry the vaccine and they may transmit the viruses to other people in the clinic, like kids who got 1 dose or no vaccine, or somebody who's immunocompromised and they could not get the vaccine for any other reason. So it's only outdoor. The mask is not recommended. But if you're meeting in an indoor, you should still wear the mask.
For your own protection and protection.
And the protection of the other people also.
Thank you. Thank you. I think we had a great discussion on vaccines. It almost went for 40, 50 minutes. I want to move on to the next topic. It's on complications of COVID infection in children. Umakant, you want to go first? Your slide?
So, I mean, regarding complication, you want me to talk about just
in brief,
multi-system inflammatory. So this is an interesting
One moment. I
condition.
don't mean to interrupt, but I think you COVID in kids, and he displayed this very nice, put things together in a nice slide. So we all remember that, and we said we want it back. It was on popular request.
Okay. Do I have an ability to share the slide? Or?
Let me give access 1 minute. Okay, let me check 1 minute. Because now we're having only doctors on the panel. Let me give.
Thank you, Prem. So while they're giving access,
So
Dr. Vaidiswaran.
Yes.
Yeah. Now, Dr. Umakant.
okay. I don't know if you can see this or.
Yep.
Yes.
Yeah, it's visible.
Would you be able to put it on a slideshow mode, please?
Yeah. So basically, as far as I mean, I think our experience here in the pediatrics, luckily, we have seen much less degree of infection, less severe infection. But we were all surprised when we started seeing this multi-system inflammatory disorder, which was like Kawasaki. It was not like a full Kawasaki, it was like a partial Kawasaki. Some patients were confusing as it is a toxic shock syndrome or streptococcal infections like a strawberry tongue kind of picture. So this is an important analogy here. So we started seeing these patients about 4 to 6 weeks after the peak of the COVID infection. So that means if the Indian subcontinent has seen a peak, you expect to see these kind of entities in children about 4 to 6 weeks later. So you need to be prepared to encounter this patient. So the most common is fever. And obviously, when somebody gets fever in the COVID pandemic era, people always start panicking that, is my child getting COVID? So typically, they present with this persistent fever for more than 5 days at least, followed by rash on the body. It can be patchy, it can be generalized, it can be erythematous, and it can be tender at time. And over a period of time, this rash exfoliates. That's a very classic feature. You can also have a swelling on the feet and the dorsal and of the feet as well as the hand. And you can also see like strawberry tongue and mucositis and crusting of the lip, which is very, very classic. In addition to that, there is also conjunctivitis in this patient. It is a non-exudatory conjunctivitis. That means there is not typically an infection which causes this. And as this condition persists, and you can clearly see that over the next several days, the complication lead into cardiac involvement. So this is how typically a patient present of Kawasaki. So this is like Kawasaki, but it's not like a complete picture. They may not have all the features. Typically, when the fever presents in the first few days, they go to the acute phase, and the fever can last several days, at least a week or sometimes 10 days, and subsequently the fever subsides. Some patients in Kawasaki do get arthritis. Here in COVID, you may or you may not get arthritis here. The most dreaded complication is myocarditis. The myocarditis can be pretty rapid and fulminant and lead to congestive cardiac failure and some patients' death. The other part is these patients can also get aneurysm of the coronary arteries. And in that area, they can develop clotting and they can lead to also cardiac dysfunction and also lead to complications. Skin, waxing and waning features, they can have nail involvement. So by the time the patients, you see nail involvement, they have gone through these multiple phases of the disease itself. Conjunctivitis, there can also be lymphadenopathy in these patients. People think it is a streptococcal infections because of the lymphadenopathy and try to treat as a strep. A lot of patients do get antibiotics. And subsequently, there is evidence of coagulopathy in these patients. And these symptoms can go for weeks and weeks and weeks. So the most dreaded complication which kills these patients is typically your myocardial involvement. And this is how it looks in a child, these kind of rashes. And it's very classic. I have seen a lot of kids of Kawasaki during my residency training here in the US. And over a period of time, there is a seasonal preference to that one. But here, we are seeing these patients more in line during the COVID pandemic. And the prevalence of Kawasaki-like illnesses is out of proportion to what we expected in the last few years. So clearly there is a temporal relation between these entities and the COVID. And clearly there are patients who tend to be very sick at times. And these are some of the other images. You can see the strawberry-like tongue here, crusting of the lips, maculopapular rash on the cheek. You can see this is exfoliation. This is a very, very classic feature of Kawasaki-like illnesses. You can, and once you see this, you don't forget them. And you can also see this here. After the rash subsides, the skin, superficial dermis, it dies and it exfoliates, and you can see these very classic features. So this is how we typically encounter children with multi-system inflammatory disorder, and it's a condition where you really need to be very, very careful because if it's undetected or wrongly treated as streptococcal infections, you can lead to these aneurysms in the coronary artery, and these patients needs hospitalizations, they need echo, they need whole workup to identify the complications and treat it.
Saraswati, can I make a couple of comments from India scenario?
Sure.
Okay, so in India, we made things a little different and simple. We classified MISC for the purpose of understanding for people that any time 2 to 8 weeks or 2 to 6 weeks post-COVID infection, were either documented by RT-PCR or you had symptoms which were suggestive of contact with a COVID case at home. So that, as he said, then we suggest, for purpose of teaching, that look for 4 things. 1, they just present to you with fever, 3-4 days. B, they come with what he said, typical Kawasaki-like syndrome, without shock and heart involvement. 3 is the toxic-like syndrome. 4 is when they present with other complications. The reason I want to say that is, in practice, when I say that if there is shock, use 10 to 30 milligram per kg methylpred. If there is no shock, then we like to give 1 to 2 milligram per kg for 3 to 5 days. So it becomes a little easy for a pediatrician. Otherwise, the pediatricians were getting totally confused what it is. So this makes life very simple for us, despite the CDC definition, WHO definition. We thought that when you have fever, CRP less than 50 and mild improving, you can get away with small dose steroids. Rising CRP, patient in shock or echo showing, so then you will have to give high dose steroids. That's how we divide it. And you'll be sad to know that we had huge surge of MISC because people were not able to talk about pediatric COVID in the second wave because there were so many people dying, adults, that we could not turn the focus of the community towards children. And the children, the data, just got a paper, Lancet from India. They took 10 hospitals, centers, they combined their data, and it was on 2,800 children. And they did show, this is a very good facts for purpose of all, that in India, 12% of less than 20 years were involved. Adolescents were more involved than younger children. Less than 10 years, the mortality was 2.5%. I repeat, less than 10 years, the mortality was 2.5%. 40% of these were with associated comorbidities in children. So that was we did not even discuss about it in media or anywhere of all these children who died. But what we want to say is the MISC, even though the Western data said 0.1 or 0.2, if you take the multi-centric data from BMJ, which says that it is 0.14%. So in India, the population is like 35 crore in less than 12 years. So out of that 35 crore, even 5%, so numbers are getting very high. And each hospital, I'm sure Chetan will agree, each of us saw not less than 30 cases also admitted under us with MISC. As I speak to you, all of us have a lot of 8 to 10 at any time. And so that is what worries me in the third wave, that now we are not out of the second wave. So what is my worry is, will we be able to tackle all that MISC and severe? So comment from Chetan about these
I would just like to add a few salient points, because what Dr. Umakant mentioned was all about the Kawasaki-like illnesses. What we see a different and variety of presentation. We have only febrile inflammatory syndrome, like patient is having fever which is more than 3 days and inflammatory markers are high. They don't have multi-system involvement. That is one group. Second group is Kawasaki-like, where we feel just we have fever and there is CRP which is high, and there is rash, few rashes, different rashes, even not lip cracking. And the third one is shock-like state. So these are the three things. Now there are, age also. You said less than 1 year, but here we have median age is around 9 years. So we have 9 to 13 years who are having a more involved. And most importantly, we have numbers are still very less, even if we are worrying about a lot about it, but numbers are not that huge, particularly of shock-like situation. We have MISI, the sort of febrile inflammatory state, and they are just getting better with just milder treatment, and even the not requiring ICU treatment. So this is some difference in the presentation of MISI-like presentation in India.
We have seen about 200 in our hospitals, MISI-like patients over this pandemic, and now we are in the tail end of the pandemic and hope we don't get the second wave.
Yes.
And the toxic shock-like syndromes, where we can count 1 or 2 patients, and most of the patients were with rash, and most of these patients got admitted because of the prophylactic evaluation for the cardiac involvement, even though they did not have Kawasaki classic. And again, we clearly saw inflammatory syndrome with the rash, and some with the complete Kawasaki, some incomplete Kawasaki, and extreme is the toxic shock-like syndrome. But the toxic shock-like syndrome is the extremely rare. The patient just crashed, and then it became like a involving multiple organs. So I think it definitely an entity which is luckily less. But if you're looking at the pediatric population, it stands out because it's a pretty significant morbidity associated with this condition.
Correct.
Dr. Vaidishwaran, any comments, please?
Yeah, actually, as a primary care pediatrician, I believe that the thing which every pediatrician should do is they should suspect each case. They should suspect. Only suspicion is going to help us diagnose these complications. Unless you suspect, probably will miss the complications. I have, in fact, suspected some cases, and fortunately, they are all good now. So probably high index of suspicion is what is going to save these children. And
so
probably we'll have a huge surge in cases after this second wave comes down, maybe in another month's time. Probably we should be very careful.
Yeah, I think that's a very important point you mentioned. It's just being very cautious about it. And I think a lot of people are not aware of this because, Kawasaki disease traditionally is not very common in India, because when I was training in India, I did not see a lot of Kawasaki disease. But when I came to US, I was seeing what is this like, I've only read in books and I'm seeing these patients here. And now we saw a lot of patients. So number one is being very suspicious about it and trying to evaluate and try to diagnose it rather than underdiagnosing these patients. Number two, the question is, do you always do the echocardiogram when you suspect MISI there in your children's, or you just wait until they become like a little bit more more prominent features?
So one moment, please.
Better to get it done.
Better
to get it.
Okay, let's finish this question. Go ahead, Dr.
It's fine. It's always better to get it done because we want to rule it out, and that's true. That even a first instance it can be normal.
Yes,
so you have to do it a follow-up after 6 weeks because you might get the changes afterwards. But you have to keep in mind, and if the facilities are available, we have to go for it. That's for sure.
I have one comment, Uma, that the experts here were thinking that one category, that is the MISC, what I said, A, not the toxic shock, not the Kawasaki, not the other multi-system involvement. But suppose if you have just fever for 3 to 4 days, which you can call as post-inflammatory, whatever you want to call, syndrome, but the CRP was less than 50, and then you know, in those you want to give a very small dose, 1-2 milligram per kg steroid within 3 days, patient improve, nothing. Then maybe that cohort, they feel that doesn't require echo or anything. What are your thoughts on that? Did you see a scenario where there was just fever, as I said, post-inflammatory, without associated very high inflammatory marker, and the patient settled very quickly? So would you want to go in for the entire?
So that is an excellent, for MISC, they put a very stringent criteria because as it says a multi-system, so they wanted other system to be involved to call it as either a skin or an eye or something else to be say that is, that's number one. Number two, when somebody
post-inflammatory syndrome rather than multi, because see, the pediatrician, as Vedi said, pediatrician doesn't understand definition. For a pediatrician, I can't say this is multi, this is, he just needs to understand fever going on post-COVID, 3-4 days. That's when he has to start thinking post-inflammatory syndrome.
Can you clarify one thing? What is post-COVID fever? That is, they had COVID, they recovered and they got fever, or the fever continued from the COVID diagnosis?
2 weeks post-COVID.
Okay, 2 weeks post-COVID.
So it's nothing to do with COVID. They've recovered, your antibody positive, and now they get the fever. That post-inflammatory syndrome, which is very common in adults also.
So as far as things are concerned, talking to my rheumatology colleagues, when they say that if somebody has just a fever and they don't have any other involvement with mild degree of markers and elevation, they just monitor them. They are not admitting them, those patients, and the pediatrician follows them up. And if the fever persists for more than 5 days, 2 or 3 days, if the fever persists more than 5 days, and they have invariably, I've seen they have some other symptoms. If it's just related to MISC, they may not have a frank cold MISC, but just fever alone, they want to make sure that you don't have a secondary bacterial infections, you don't have an ear infections. You want to make sure that you also rule out the COVID, because any viral infection can give rise to secondary infections. So they are ruling out, but they are not used any steroids in those patients who just have fever for 3 to 5 days post-COVID until they go into some degree of involvement, which looks like MISC, just to be consistent. Again, luckily we have seen much less case right now. So we'll see what changes happen in the future, but at least we are not using steroids.
I've seen that in my schools. They also just give naproxen for 3-5 days, and then they see if the fever persists or the inflammatory goes, then only steroid. I get it.
Thank you. Thank you. Dr. Vaidishwaran, from your experience as a primary pediatrician, what are the commonest, there was a question from the community, what are the commonest signs and symptoms that they need to look out for? Adults, if a family, the parents, right, both the parents got COVID and they're always scared, there's always a fear that the children could be COVID positive as well. So can you just brief out few points?
Yeah, in my experience, most of the parents, the first thing they do is they get panic. Once they are diagnosed with RT-PCR positive, then obviously they become panic. The child is normal, right, on that day. So most, the common mistake what they do is they ask their grandparents, nephews, or their relatives to take the child with them, thinking that they are going to be okay. Unfortunately, I have seen instances where children, once parents become positive, they have sent the child to their grandparents. After 3 days, the child developed fever. The grandparents also got the infection later. So it's going to be a complication, actually. So what I suggest is, once you get fever, the possibility, particularly with this Delta variant, is going to be that most probably your children is also going to get positive sooner or later. So I would suggest all of you, you be it at your home, please don't send the children anywhere. And even at home, you wear mask, try to keep physical distance, and also follow all the corona etiquette which we teach them. So probably they can keep the children at home. And I usually ask them to follow. Nowadays we do more of telephonic consultation, so online consultation. So they can follow up with their pediatricians. So as long as the child is well, the child is active, the child is drinking well, eating well, otherwise the child is active, I don't think there is a need for any worry. So the number of days fever doesn't matter. So a child's sick on even child can get sick, very sick even on the day 1 of fever. So the child is having some problems even on day 1, then probably we have to review the child and we have to follow up the child. Some children, they can be having fever for 4 or 5 days, and still they will be very active, good, and I don't see any problem with them. So that's the basic recommendation we give, and most of the children do well with this.
So is there anything that the parents have to take once they are infected? I mean, I know the incubation period is there. The child could have, there's a possibility that the kid could have already been exposed. But is there anything they can take? If one family member or the grandparent is affected, is there anything that the parents can take to safeguard the kids as well?
Of course, any family member gets affected. The possibility is that other family members are also going to be affected. But once you test positive, or you have a suspicion that you are going to have COVID, then probably the first and foremost thing will be to isolate the person. Suppose, for example, if the father is having fever on day 1. So what I suggest is better you please isolate yourself. The other family members, they can, if possible, they can live on another floor, or if it's not possible, they should at least limit themselves to another room. And all of them should wear mask at home, even at home. So that's what I recommend, so that probably the chances of getting infection, if not infected earlier, is less. So that can be practiced.
One quick question to you. Lactating mothers positive. So can they continue with the breastfeed? That's number 1. And 2, yes. How close, how proximity, hugs and kisses, just the cuddles. Can they do that? Cannot do that? Can you light on that?
Yeah, it's a tricky question, actually. It's a tricky situation. And what I suggest is better continue breastfeeding. So as long as we know, breastfeeding is obviously when the mother gets infected, she's going to produce some antibodies, and it's going to get transmitted to the child, newborn, or maybe an infant, and it's going to be protective. And I don't see any reason leaving the child to others. Suppose, for example, a 3-month-old child, who is going to take care? Nobody is going to take care. In fact, the child is going to have a lot of problems if the child is separated. So better mother can take care of the child, and if there is any problem with the child, we can take care of that. Obviously, the symptoms are minimal in children, so probably we will think positive and we'll take care of that. So better continue breastfeeding, and you can nurture the child yourself. That is the newborn or the infant.
And the mother should wear a mask.
Definitely. So anybody, anyone having fever, we're not worried about the cause of fever. So if you have, even without fever, if you have headache, body pain, tiredness, you start wearing a mask. Right. That's a safe option.
That's what the 2 important messages. A, where the mother should wear N95 mask.
One moment, Dr. Mohan. So my question was halfway through. So can they see the cuddles?
It should be N95 mask. We should give the message, because the mother is going to be nursing the baby. Second, also take an express breast milk if it's too concerned. So these are the 2, but breast milk is a must. That message should go.
That's the protective one for the baby.
Obviously.
And, and also for all other immune antibodies and everything else, breast milk is the best milk, they say, right, for babies. And one thing is the hugs and cuddles. Mother to child, the infant is only 3 months. And the other issue is what kind of man. It's going to be so hard, because the newborn babies, they get cues and facial expressions from their parents and their grandparents. So if the parent is wearing a mask, the baby is going to miss those things. So what are long-term effects of that? That's the second part of the question. But the first part of the question is the hugs and cuddles.
So
give hugs and cuddles if she is wearing an N95.
So I think what we're trying to see is, this is a situation where routinely we are not in. I mean, this is hopefully a week or 2 week situation. It's not going to be there for like 6 months, where the development of the child will be affected. Number 1, the message is safety, right? So the point is, if the child gone to a mother with an infection, the first thing you need to check whether the kid is already infected, right? If the baby is already infected and the baby is asymptomatic, you can continue contact with the mother. Number 2, if the baby is not infected and the mother is infected, now depends how much symptomatic the mother is. If the mother is very symptomatic, where she herself needs the care, then obviously she either be to the hospital or she takes treatment or wherever she has to be there. If mother is very mildly symptomatic, positive, and the kid is not infected, that's a tricky situation where you're trying to keep together in the home. So in that situation, as Dr. Mohan and everybody said that, I think we should continue the bonding with the patient with the N95 mask. And here, the important is safety. You can still hold the baby. You can, the infection doesn't happen by holding and touching the baby, but at least close face to face, kissing the baby without the mask. I would recommend not to do that for at least for a period of time until the mother becomes negative. In that situation, if she's doing that, it is about 10 to 14 days from the day of the onset of the fever. You can take that symptoms. So that is more important. And I'm not worried about the long-term situation for a baby who's just born for a 2 weeks or a 3 weeks period. And if the mother is sick, if the father is not infected, he can take care of the patient. Or in India situation, grandparents are there. I think the problem becomes tricky in places like US where only single mothers are there, and places in India where only single family members are taking care. That becomes tricky. So that's what I think. Sometimes it's more of a common sense approach of what the knowledge we learned about COVID all the time, rather than a specific guidance.
As far as the mask is concerned, even though mother is wearing mask, the child not only gets its inputs from the facial reaction, obviously the touch, the sound of the mother, smell, everything has a cues to the baby. So obviously the baby may not feel isolated. So it should be good. And regarding the breastfeeding, the WHO recommends that if the mother is well, the mother is able to breastfeed, she can continue her breastfeeds. The second best option, if she is sick, then probably if she is sick to breastfeed, then probably she can give her express breast milk. The third option, the mother is not fit enough to give your own express breast milk. The third option which can be practiced is wet nursing, if possible. And the fourth one is breast milk bank. So they have a lot of options to continue with breast milk. They can do properly, try that.
So one thing you have to tell that is you're not going to put the mask on the baby, okay? So you're going to protect the baby. So a lot of people may ask, like, if the baby is positive, mother is positive, they're trying to prevent infection of the other member of the family, don't put the mask on the baby. That's the one message you should always tell that, because, you know, it sits and all these things, suffocations are very common, and you can rather kill the baby rather than try to save other people.
I think this is the most important message for young kids. Thank you, Dr. Umakant, for bringing this up. No mask on
babies.
Yes. And one more thing on the same note, testing for children, right? You said if the mother is positive, okay, you can get the baby also tested. But if the baby is asymptomatic, do you really want to get the 3-month-old or a 5-month-old tested?
Oh yeah, absolutely, because kids can be asymptomatic, right? So you need to test them.
In fact, the newborn Saraswati, the testing recommendation is twice. One is on day 2 and one is on day 5. In cases where you think you have issues with, you know, the neck doing so much, then they would have said that the recommendation by WHO is to test for the infant day 2 and day 5, just to make sure that they don't get intra-uterus. So that's day. And another message, one question I had for Uma is, the WHO had said less than 5 years no mask, but the CDC and USA said that more than 2 years wear mask. Your thoughts about it? Because when the Indian government gave guidelines, they said 5 years like the WHO, but clearly the CDC said more than 2 years wear masks. So what was the controversy, and how did you all decide to give masks to more than 2?
So as the American Academy of Pediatrics came, it's, you know, there are so many organizations, sometimes you get, you know, when they don't talk in the same language, you get confused. So CDC, and especially we take more of the guidelines, especially for the pediatrics, in addition to the CDC, the American Academy of Pediatrics. So they recommended no mask for less than 2 years. So one, it was harder. Number two, it's again
more than 2 years, that I understand.
Yeah.
2 to 5 years, how did American Academy decide against WHO? What happened? Because in India we could not.
So again, I don't know what were the discussions they went into that one. They felt that a 2-year-old or more than 2-year-old can have enough aerosolization where they can actually transmit the infections compared to the younger kids, because their aerosolization doesn't reach that much. The infectivity of a younger patient infecting other people in a given situation is less. And that's what they recommended. Again, these are all, in my opinion, to some extent made up. There is no controlled trial where you take a 2-year-old and a 5-year-old and a 6-year-old and try to infect people. So this is based on some of this in lab studies of giving some spray and then see how far your jet goes, and then trying to base recommendation based on those things.
Right, and it's
We
the
should
same
not
thing.
stick
Go ahead,
to
Doctor.
the age, specific age. It is at the age where the child can manage the mask. That is, I think that should be a thing, because there are kids, even 1.5 years, they are wearing masks very nicely. So only thing is, if he is able to remove the mask, he is having smothering, he should be allowed. He can be allowed.
I think that's a fair point. But what happens is, a lot of people don't have that degree of comprehension to they may try to put the mask in spite of the kids. I think
That is
so.
that is not.
I think when the guidelines come up, people are trying to make it. I completely agree with you.
So we should not follow the guide.
Going to throw off. So
Correct.
they're walking in the clinic, even 5-7 years old, without a mask.
So what I advise, many people, they are very adamant in putting the mask to the children, even if you advise against that. So I advise you better go with face shield. Why do you want to put a mask? Better you have a face shield, at least for their satisfaction, even if it's not working.
I think kids are getting used to adults with a mask and they are wearing the mask. But I think.
So I feel actually in adults wearing the face shield, adults itself, it's a little hard to educate them. And face shield is a great idea. Okay, with mask or without mask. These days, in my clinic, I see patients who are walking around. They come with the face shields alone, but no mask at all. So that's one thing which is happening in the adult population. And the kids seem to be doing really well. More than 2 years here in the US, they seem to be doing really well wearing their masks. I mean, no questions asked. Maybe they have a fight with the parents at home, but then they kind of see other children. When they see other children wearing the mask, they feel highly motivated, right?
Especially when they started the school in person and the school was mandating the mask. And other than the sensory kids, like almost everybody wears the mask here. I mean, it's just
right. They're doing well.
I think, okay.
You're muted.
We are at 10:30 now. There are so many more questions. Actually, we didn't even touch much on the third wave and even other questions which are in the chat box. We would love to have you all back again for a COVID and Kids session 2. And a lot of questions among us and the community as well. One last question I see here from Sharon KB. After this, I just want to introduce Dr. Suresh Reddy, who's here with us as well. How safe is it for kids to get vaccinated, given the long-term side effects are still unknown? Will the natural immunity of the kids, is that good enough or not? That's from Sharon.
Issue is whether you want to get your kids vaccinated or not. But the issue is government is one is we have to get children vaccinated at any one given point, because you know that children are making 25-30% of the cohort. So if you want to reach to herd immunity, you have to cover up the children. Second thing, yes, children are getting less infection. They are less severe infection because of maybe they are having a less AC receptor in the respiratory tract, or maybe they are having some cross protection because of some other viral infection, or their immune system is already been stimulated because of so many vaccines, and they are not having some comorbidity like other than obesity, they don't have any comorbidity like hypertension or diabetes. So yes, they are having some advantage of not getting bad COVID, right? As of now, what our experience is. But when we go start the school, see, you have to start sending your kids out. How long you can keep it there? So first, we have to get the safety of the data, safety of the vaccination in children. That's why we are telling, yes, we have to first establish the safety, then only it has been allowed. But looking at the threat or fear of a long-term complication of the vaccine, I think we don't have any answer, because we can't be very sure of any long-term complication, even for adults also. But as of now, it has been proved that vaccines are safe. And because of the technology which has been used for this vaccine manufacturing, we are safe. They're not going to cause any long-term complications. So we have to vaccinate our children at one point or other time. So we cannot get away without getting vaccinated our children.
And Dr.
Sure.
On that point also, to your point, to extend that, I think we already been giving vaccine kits for other viruses, other infections. So there is a huge history of vaccination safety, like polio, diphtheria, tetanus, measles. They are like live attenuated vaccines. These are already been tried, and I think, in fact, it has helped to improve the health of the kids rather than hurt them. And I don't think so there is a long-term immune issues other than some outliers where underlying conditions may have had a bad reaction to them. But I think the vaccines are safe, except few who invariably are known to have side effects for any vaccines. So I think it will prevent infections. And this is no different than those vaccines which is already existing.
A concern can be there because it is EUA as of now.
Yeah.
Other vaccine have been there. I studied for almost 5-10 years, and then it has come to the market. But there are some concerns because it has come very in a short span of time.
And especially
But
the
yes,
mRNA vaccine, Dr. Trivedi, because that's a new technology. There's no vaccine,
correct.
mRNA vaccine before. And we are all guinea pigs, right? I mean, we have taken it. And with a leap of faith, we have taken this vaccine. And the first is to survive.
Yes.
And the side effects.
Correct.
Thank you.
Probably we were happy that we got a live attenuated vaccine of proven technology and
Yes.
Covaxin of proven technology than getting an mRNA. That was our initial thoughts.
Yeah, I completely agree with you. It's better to go, but again, there is a new, now the mRNA technology, what I can tell you is if that proves safe in a short to medium to long range, there are a lot of therapies which can evolve from that. We've been talking about vaccine for cancers, and that will be based on mRNA technology. So I think we will get a lot of treatments, some of the diseases which are not treated based on this new platform, which was people were not doing this because they thought it was a bad thing to do. But when the pandemic, everybody's pushed to the wall. So it's a survival of the fittest. So people brought this technology, and so far it has proven to be very safe and one of the top most effective vaccine out there. And second, if it sustains this way and prevents long-term complications, I think it just opens up the flood door for all the rarer conditions like cancers and other things we can treat with these vaccines.
Yeah, there are only two ways we tide over this pandemic. One is getting an infection and surviving the infection and getting immunity. Another one is getting a vaccine and avoiding the infection. So we have to choose either one of that, and we know which is the safer one.
Yeah.
Correct.
Yes.
Saraswati, I should start complimenting you for an awesome moderation that you did. You were awesome and generated such interesting discussions from all of us, Saraswati.
Thank you. Thank you so much. Thank you, Dr. Neelam. Thank you very much. I would like to invite Dr. Suresh Reddy, who's here with us. I do have to mention a few things about Dr. Suresh Reddy. He was the past president of American Association of Physicians of Indian Origin. And he's a role model for all of us. The energy, the amount of motivation he has, and the level of energy. He's like a go-getter. And recently, he makes us all so proud. Recently, he won the Oak Brook elections. He's in the board there in Chicago. And he's helped so many people, not only in API, in the US community as well, and the American community as well. Dr. Suresh Reddy. And I do want to thank Dr. Suresh Reddy for introducing us to Dr. Neelam Mohan. Thank you for that.
Thank you, Suresh. Thanks from my heart for that. And yes, Suresh is moving from Osmania to each other, and he's done everybody proud in the campus.
Right. He's like a friend of everybody. Dr.
Thank
Suresh.
you. Thank you, Saraswati. And hello, good morning, all the Tamil viewers. Iniya Kale Vanakkam. And I see my good friends here, Neelam and Sarvanan, and especially my Boston friend Umakant and Saraswati. It's a pleasure to see all. Like Saraswati is so motivated. Actually, she is also inspirational, including me. So very inspirational to many people with limited resources she has. She is like an amazing person, and hopefully I'll see her as one of the top leaders in API someday. But I thank you again. Thank you. It's a wonderful topic. This is what we started last year from API, and it's continuing into all the sub chapters. Actually, I take a little bit credit for ATMA, including with Kalai. ATMA became the chapter of API under when I was the president. So that's a very proud moment because I was the first API leader or president to go to ATMA meetings. And when I went first time, I didn't know anyone. Then now I know hundreds. So it's a very proud feeling that ATMA becoming part of API as a subchapter, and we are all under the same big umbrella. Thank you all. It's a wonderful talk, wonderful topic, and please let us know anything from API. We have wonderful leadership for the next 3-4 years, and in API, so they all want to work closely with the sub-chapters. That was one of my mantra when I first took over, that connect with sub-chapters, connect with alumni chapters. And we were successful. We have a long way to go, but I think one step at a time, we are doing an amazing job. Especially COVID brought the entire medical fraternity together. It doesn't matter where you are from. So that's a very good feeling. And thank you all. Thank you, Saraswati. Thank you so much.
Thank you.
Thank you, Dr. Suresh. Thank you for coming in spite of your busy schedule. We really appreciate that.
No, thank you.
As I said, we look up to you. You make us all so proud. And we are hoping to see you in Washington, D.C. sometime soon.
Yeah, no, ATMA, yeah, definitely, yeah.
Thank you. Thank you. Dr. Saronan?
Hello, Dr. Suresh Reddy. Thanks for joining, Dr. Reddy. As Dr. Reddy said, I completely agree with what he said. So Dr. Reddy, I met him in 2016 ATMA convention, which I was a core member working with Dr. Kalai to help. And from there, it's a very good friendship. Dr. Reddy helped me a lot. I mean, guided, helped. He's a phenomenal person. And the relationship between ATMA and API is growing exponentially after Dr. Reddy. Not only ATMA, I think he's phenomenal. He's helping, I mean, every organization. And I'm so thankful to Dr. Reddy. For me, I can always call him for any help. Okay, I mean, personal or organizational help. He always did that. Only one thing I want to say that it's not against, but ATMA started this program. This webinar long before the AAPI, and but AAPI's magnitude is really high. They did phenomenal. They connected the global leaders. Not only India and all over the US, all over the world. And Dr. Reddy particularly, as Dr. Mupana says, I drive some energy from Dr. Reddy. Looking at him, I can do at least 5% of 10% what he does. Okay, so
actually,
Dr. Reddy,
also credit goes to ATMA. I agree, Deepta and Niranjan, and they are the first ones who started this webinar, and API took that idea and took it a little bit further. So, but the real idea really came from ATMA. So that definitely goes to ATMA.
And I know Dr. Reddy is always help. Whether it is his friends or his non-friends also. He's such a sweet person. And thank you, sir. Thank you very much. And as Dr. Mupana says, it should go. You should go. Far distance in the American system. We expect you to go there, sir.
Thank you.
And at the same time, I would like to thank all the ATMA office bearer, also Dr. Kalai, chairman of the board, Dr. Ashok, president-elect, Dr. Einstein, Arunachalam Einstein, president of ATMA, Dr. Deepta, tirelessly working and helping everybody. The list goes on. I don't want to thank Dr. Mupana. Dr. Mupana is here. She's part of our team. So the list goes on. And the speakers, I really, I want to thank all the speakers spending your time, preparing the slides. One thing I can say that I learned a lot from today. I learned a lot about pediatrics, the pathology slides, radiology slides. We were like very earlier to demonstrate to everybody, and we learned. And still, as Dr. Mupana said, still I remember Dr. Katwa's slides. Oh, that's like, because that is a time in the New York City, there was 3 cases has been reported and admitted. And every speakers, please do not mistake, I'm not mentioning them. Every speaker's been here before, And now I'm really thankful to all of you for coming here, as well as the sacrifices and services you guys are doing. Thank you. Dr. Mukha, you can take over, please.
Thank you. Thank you so much, Dr. Suresh Reddy, and thank you so much, Dr. Saravanan. Any closing statements, Dr. Vaidishwaran, please?
Yes, I thank the office bearers for this opportunity, and Saravanan is my classmate and is as energetic as always been. And I'm sure ATMA will do a lot of good work. And I would like to thank on this occasion, take this opportunity to thank ATMA for having rendered an excellent help to our state in this panel. Thank you.
Thank you. Thank you so much. Dr. Umakant?
Hi, Saraswati, thank you as always. You know, we are in Boston. Our house is about like 3 miles away from each other, and we always meet on Zoom rather than in person.
Right.
But either way, we need to change that soon with the vaccine. So first of all, I want to thank you and your organization for hosting this seminars for community and doctors. And number two, a special thank to all my colleagues in India, Dr. Mohan, Dr. Vaishavaran, and Dr. Trivedi. I think you guys are doing an awesome job. You are in the midst of a pandemic. It all hell broke loose in such a short period of time. And looking from here, looking at you guys, the amount of innovation you guys have done, the amount of challenges you have faced, in spite of having less equipment, you stood there and you did not run away from that. And in spite of that, putting your life at risk and helping my country watch it. We feel sometimes helpless being here, unable to do much. But whatever we can do, I'm trying to do in different ways and forms. But hats off and thanks for all the work you do to us and to my motherland. Thank you.
Thank you. Thank you, Umakant. Dr. Mohan, please.
Yes, I'm very indebted to Saraswati for connecting to me. Thank you, Suresh, for having recommended my name. And it was a wonderful session where we all exchanged the wisdom pearls, as we called, because there was so much to learn from each other. The best thing to learn was how to give to the community. That is very important. And so all of us tried to share our knowledge, and I'm hoping that the people who listen to this would find it useful. So please drop in your comments to whoever is the organizing person, because it is through those comments that Saraswati will be able to improve and get more people, or delete some people, because your comments are going to be very useful. And I look forward to the second session that you said, a part 2 version of it. And I would again thank my colleagues who had joined me, and Umakant. I look forward to flying down to Boston and having a with you.
Yeah, please, anytime. If you come to Boston or US for any conferences, please do visit us. I can show you around here, my hospitals and places around. Anybody, it's an open invitation to all my colleagues.
Thank you. As Umakant said, we live only 3 miles away from each other, but then we meet only during the national conferences or RP meetings or these Zoom conferences. So that's been the nature of lives these days, actually. And Dr. Trivedi, any closing statements, please?
Yeah, thank you so much, Dr. Mupanna and Dr. Saravanan and ATMA for a wonderful opportunity. And this is a very hard work what you're putting in, because we know that every week, that too on a Sunday, you have to do one program. That too, keeping a good quality, getting a good speakers, and it requires so much of inputs. And so hats off to your inputs. So that's wonderful job you are doing, and you are just trying to enlighten all the audience, like maybe a physician, even a non-physician, non-doctors also, because ultimately knowledge sharing will definitely improve the confidence in whatever the system we are working in. Because this kind of pandemic requires so much of confidence boosting or moral boosting. That's what Dr. Umar Khan mentioned, that just a word of, these kind of words, they literally, keep us going. So we all are working for betterment of our own mankind. So we should be working in the same fashion. So thank you so much for the wonderful opportunity, and we'll be looking forward to further sessions. And thank you so much.
Thank you. I do. Dr. Saravanan, you want to say something? Thank you, Dr. Trivedi. Thank you very much. So I do echo everybody's sentiments, starting from saying that we are, like Umakant and Dr. Saravanan, and we are all here on the other side of the storm. and they're watching the storm, but you are all in the front line, and you're putting your time, energy, time away from family, doing all this stuff, and also taking care of the patients. It's not been easy, but there is hope, light at the end of the tunnel. And I think rather than fear, we should have our strength in the faith. I think that's very important. And it's also important, just as the other speakers said, and you mentioned as well, Dr. Trivedi, it's also important that we stick together, learn from each other. And Dr. Neelam Mohan was also mentioning, we learn from each other. These sessions are really enriching for all of us. And especially for me, I feel I learn a lot just talking to all the excellent expert opinions we have here. And the knowledge is going to transcend. We are training the trainers so they can also train the other people. And then when it comes, we are talking about the cities, but there are so many people being affected in the rural areas. And that's where the community comes in. And that's where the teaching and training the trainers comes in. So they can go and educate the other people there in the community or in the rural areas. So it is, knowledge is power. And I think that's what keeps us going. That's what is really important as well for the healthcare growth and every growth. So I would like to thank ATMA very much. Thank you, ATMA, for giving me this opportunity. And thank you for COVID-19 Tamil Task team. This is not just for Tamil people or Tamil Nadu, it's for everybody. People in the US, people in India, and everybody, whoever has connections now, because we're talking more about the crisis in India. Anybody who has connections with India, it's for all of us. We're all in this together. I would like to thank the technical team, Prem, and all the other team of ATMA and the volunteers who've been working tirelessly day and night. This is one of the services that the COVID-19 Tamil Task team offers. There are a lot more which is going on in the background, like finding beds, finding ICU beds, oxygen concentrators, connecting people to resources, including resources like pharmacies, local pharmacies, where can they get amphotericin, or where can they get the 2,3-DG, everything. So we want to thank all the volunteers for the COVID-19 Tamil Task team and ATMA for tirelessly working 24/7 for the cause, for this cause. And thank you, Dr. Saravanan.
I have one point, Saraswati. So I think we did not get time to touch base on the hypoxia part of the things in children and as such, the physiology of hypoxia. So in my hospital, I'm trying to put some webinars and lectures to record with our respiratory therapist, how simple, how effectively you can manage hypoxia, because, people panic with oxygen. It's not about how much oxygen, it's about the art of using oxygen and art of how you try to prevent intubation. So those are the things at some point, not that, the good news is that the pandemic is dying, but the bad news is we never know when we'll have the next pandemic. And I think the lessons learned is, you can be once foolish or twice foolish, but you cannot be foolish all the time. So we need to be prepared next pandemic. And I think India will do a great job with the next pandemic. I think they learned their lesson from, like we have learned our lesson with the second wave, and people have learned from the lesson. But it's an evolving lesson, and nobody's smart enough because the virus is getting smarter by every single line. Now, when you give vaccine, it tries to figure out, how I can bypass the vaccine. So those I want to tell you that I will put up some webinars and other things like recorded things that people can share them for hypoxia.
So that's going to be the session 3 now. Okay, so the next topic we were thinking about is regarding mucormycosis. Does it affect children? And not only that, the third wave and hypoxia and the oxygen. So these are all kind of related in a way. So I think we should definitely do a second session as well, if the panelists agree. I'll get in touch with you all later.
Awesome.
So, Dr. Saravanan, do you want to finish it?
No, I'm good. Thank you very much once again. I mean, I have no words to say. I mean, thank you everyone for the time. Time is the most important. Thank you, Prem. I mean, Prem is tirelessly working, and as Dr. Mopana said, I thank the volunteers. It's wonderful volunteers from March 2020. They've been working really hard. And I thank every one of them at this moment. Thank you.
Thank you, everybody. Thank you for your time.
Thank you.
Thank you.
Thanks.
Thank you all.
Thank you. Bye.
Thank you.
Bye.
Thank you all.
Thank you.
Bye.
Did we take a group
Recording
picture?
stopped.
The
Recording in progress.
take a group picture after the recording is stopped.